In angle closure glaucoma, recently much interest has been generated regarding the use of lens extraction, the utility of lens extraction in the management of angle closure glaucoma. Most of my talk would revolve around this topic. We all know that there are various predisposing factors for primary angle closure glaucoma. A decreased axial length, shallow anterior chamber, a narrow angle width, and a small radius of curvature of cornea. Shallow anterior chamber, if we see, is caused if the irido-lenticular apposition leading to relative pupillary block is well known, and this supports the pivotal role of the lens position and size in the active or the potential mechanism of angle closure. Now, the ability of lens extraction to control glaucoma in angle closure would depend on the extent of reversible component of angle dysfunction. So, if we have appositional angle closure which can open up following lens extraction, then that's something that might help in improving the outflow facility. It would also depend on the target pressure for the particular eye, and the angle function, as we know, can be compromised not just by peripheral anterior synapse but the irido-trabecular contact per se. We'll start off with acute angle closure attack management, and from the AGIS consensus statement in 2006, it was concluded that laser iridotomy should be performed as soon as feasible in the affected eye and then as soon as possible in the contralateral eye. Medical management was the recommended first step in treating acute angle closure. Primary cataract extraction, they said, may be a treatment option, but data supporting its use was limited. Lam et al. Have conducted a randomized control trial of early phacoemulsification versus doing a peripheral iridotomy in preventing intraocular pressure rise after acute attacks in primary eye closure. So they compared the efficacy of early phaco versus a iridotomy in preventing intraocular pressure rise in patients after acute attack. They had 31 eyes in each arm, and this was a prospective randomized control trial. Now, what were the results? They showed that the prevalence of intraocular pressure elevation at 18 months was 3.3% in the phaco group and 46% for the iridotomy group. The angle was significantly more open after phaco compared with LPI. There is a significant difference in the mean number of glaucoma medications that were required to maintain IOP less than 21. In the phaco group, it was 0.03, whereas it was much higher in the iridotomy group. So that is a huge case for lens extraction in acute angle closure. But then let's look at what's between the lines. Now, these cases were those cases of angle closure where they had been able to abort the attack by using topical and systemic anti-glaucoma medications. All these eyes had presence of cataract. So that's very important to note. All these patients received phaco or LPI within days after the abortion of the acute attack. As soon as the intraocular pressure could come down below 21 and when the inflammation had settled sufficiently for safe intervention. So it's only in this situation that what we have heard so far might hold good. So we cannot look at unaborted attacks and try and do phaco in those hot inflamed eyes. If we look at this table that they have given regarding the baseline data, the onset of self-reported symptoms to consultation was 2 to 3 days in the phaco group and the LPI group, and we know that in India many times this can even stretch to months. Okay, so very often we see patients not reporting within 2 or 3 days, and they come even they would have been treated elsewhere. By the time they land to maybe a week, 2 weeks, or even much later. The time needed to abort attack on an average was 11 hours in the phaco group and 9 hours in the LPI group. So the eyes have been easy to settle down. The time between the abortion of attack and the phaco was about 5 days in both groups. Now, another important thing that we need to look at in the study was what was the complications that they saw. In the phaco group, they had intraoperative corneal edema in 12 eyes, posterior capsule rupture in 1 eye, intraoperative bleeding from the iris root in 1 eye, postoperative fibrin AC reaction in 7 eyes, and visually significant PCO in 5 eyes. The LPI group had one closed iridotomy and small iridotomies as the complication. They also mentioned in their study that the phaco was performed by a single experienced surgeon, and these results may not be generalized to the less experienced. So the risk-benefit ratio of phaco in eyes with good visual acuity after abortion or in those eyes with no cataract is a subject of debate. So the study clearly says these are eyes with cataract, and though maybe we could extrapolate, but these are not eyes with clear lenses. And this may not be valid for other scenarios, especially unaborted acute attacks. I do think the complications are a little unacceptable. Early presentation in India may not always be the scenario. They have not mentioned as to how many of the eyes they could not settle with anti-glaucoma medications. Many times we see that the eye finally settles down only after you have done a LPI. Giving any amount of mannitol or any other topical systemic medication does not settle down the eye, and it's only a LPI that finally quietens. So I would prefer that. Why do we need to make a choice between iridotomy and lens extraction? We could do the iridotomy, allow the eye to settle down, and yes, if we still think that the pressures are going up, we can always do the cataract extraction a month later or so when the eye has well settled down. Acute intervention with lens extraction as primary treatment in APAC still remains less appealing than conventional methods. Now, while we are on the same topic, we'll also talk about peripheral iridoplasty, argon laser peripheral iridoplasty in acute attacks. Lam et al. Did a study and again compared iridoplasty versus systemic medical therapy in the treatment of acute primary angle closure, and they found this to be a safe and more effective alternate to conventional systemic medications in the management of acute PACG, which were not amenable to immediate LPI. And this was within the first 2 hours from the initiation of treatment. So only in those eyes where LPI was not possible, iridoplasty might help in being effective as an alternative to medications in breaking the attacks. If we look at iridoplasty for angle closure, which is non-acute, then this does not hold good. There was one RCT with 158 participants, and at the result clearly said that there was no evidence for its role in the treatment of chronic angle closure. There was no superiority either for the intraocular pressure reduction or for the number of medications or for the need for surgery. They did note a significant reduction in PAS, the peripheral anterior synechroplasty, but the authors acknowledged the limitations that the gonioscopy was done with the Goldman lens, not with the indentation lens. The outcome assessors were not marked, so we would not look at iridoplasty for the long-term management. Now, if you look at lens extraction itself in primary angle closure glaucoma, Friedman et al. Did a database of systematic reviews for this lens extraction in chronic angle closure glaucoma, and they did not find any randomized trials at that point. They found 2 non-randomized trials, but they said that both the studies had poor methodological quality. Comparing lens extraction with other treatment modalities, they in the studies, clear lens as well as cataract lenses had been included. Phaco and ECCA had been done, trapped with and without antibiotic. So the information did say that maybe there's a biological plausibility and the effect of treatment may be good, but there was no proof of effectiveness. There were no other comparisons made with other forms of treatment for PAC, chronic angle closure. Similarly, Teranga et al. In 2009 in Survey of Ophthalmology made a simple statement that there is no evidence from good quality randomized trials or non-randomized studies for the effectiveness of clear lens extraction for PACG. Dr. Ravi Thomas et al. In their article in 2011 have again reviewed the literature for the role of lens extraction in PACG. In fellow eyes, they say the iridotomy considerably definitely reduces the risk of acute angle closure in a fellow eye, though we know that it does not entirely eliminate the possibility of another attack. It is a minimally invasive step, and so it should be the first step for such eyes. And clear lens extraction for the fellow eye is definitely not justified. LPI was able to prevent acute attacks in all 80 fellow eyes in this study by Ang et al. So fellow eyes, we would look at doing a LPI. Now in PACS, we know that the risk of acute attack is 0.1% per year overall and 1% per year over 60 years of age. Now even LPI is not standard treatment. We don't do LPI for all patients of PACS. Definitely cataract extraction may not be indicated for visual, cataract extraction would only be indicated for visual reasons. Clear lens extraction is definitely not indicated for PACS per se. In primary angle closure, initially conventional laser peripheral iridotomy and anti-glaucoma medications are what we look at. However, if the angle does not open post LPI, if there is raised IOP despite LPI, if there are recurrent attacks, if there are persistent symptoms, if the pressure is uncontrolled with medications and argon laser iridoplasty, and if the sufficient area of the angle we see that can open on indentation, one could consider lens extraction. There is no data to support combining clear lens extraction with goniosyncytial. However, I do think that if there has been an acute attack and a recent onset of posterior synechiae, personally it does seem to work well if the synechiae are recent, the inflammation is controlled and one does a careful procedure. They do tend to help. However, I do not think that they have the same role if it is chronic angle closure. Seems reasonable to believe that if lens extraction would help, whether it is a clear lens or a cataractous lens, the angle architecture would improve and the benefit would apply whether we are removing a clear or a cataractous lens. But what we need to remember is that the risk-benefit ratio then just gets higher. We have two major RCTs from Tham et al. Where they have studied phacoemulsification versus a combined phaco trap in medically controlled and medically uncontrolled chronic angle closure glaucoma in the presence of cataract. One deficiency here is that the extent of appositional or synechial closure has not been clearly mentioned, because like I said, the benefit of lens extraction would depend to some extent on the presence of appositional closure. In both groups, they found that phaco alone, not doing glaucoma surgery but phaco alone, was comparable with the phaco trap. However, there was a greater need for use of postoperative glaucoma medications in the phaco only group. Intraoperative complications were similar in both groups, and these were basically related to the cataract surgery. But postoperative complications were higher in the combined surgery group, and these were almost entirely related to the trap surgery. In the medically controlled group, combined phaco trap with mitomycin C gives a marginally more effective pressure control than phaco alone. This was resulted, however, in more postoperative complications. These were not very serious and they did not translate into any form of worse clinical outcomes in terms of vision or the visual fields. Now, what we would want to look at when we are deciding on what we want to do for a patient is to see whether this marginally better intraocular pressure control with combined surgery justifies the potential additional risk of complications and the additional surgery that might be required, say for a oblique or for a shallow AC, in handling these complications or to improve the filtration. Cataract extraction alone may be useful in cases of medically controlled PACG, where there is some degree of appositional closure that can be opened. The addition of a trap may not be needed, provided a continued requirement for the use of glaucoma medication is acceptable to the patient. So the patient needs to understand that if his cataract alone is removed, there may be a need for the use of glaucoma medications. Chronic angle closure eyes with phaco alone perform a very small percentage, 2.9, eventually required a second stage trabeculectomy. In the medically uncontrolled, combined phaco trap definitely gave lower pressures than phaco alone at all time points. This was about 1.5 millimeters, though this was not statistically significant. Clinically, we do think this might be significant. 4 eyes in the phaco alone group eventually required trabeculectomy. However, the trabeculectomy did not fare worse in any way. It had good results. More post-operative complications in the combined phaco trap, but again it was not reflected in the vision acuity or in the fields. Mean postoperative number of topical drugs on an average was much lower in the phaco trap group. In the medically uncontrolled group, addition of a trabeculectomy may provide a significant IOP reduction. Now, what happens if the same situation is there with the clear lens? Like I said, we could probably look at extrapolating the results, but understand that there is a higher risk to benefit ratio. In medically controlled glaucoma, if there is no cataract and the pressures are already controlled with medications, why are we even looking at surgery? So there is really no indication for surgery unless the patient is intolerant to medications, you want to decrease medication, and then if so, we could probably consider trabeculectomy alone. If lens extraction alone is planned, what we are concerned about is, will the intraocular pressure reduction be adequate? Possibility of IOP spike post-cataract surgery has to be kept in mind. And later, if we still think that trabeculectomy is required, we would need to wait for 6 months for the inflammation and the eye to settle down so that the trap works well. So, in conclusion, there are no RCTs that actually support the use of clear lens extraction as a treatment for angle closure. A benefit from the procedure is biologically plausible. Extrapolation from existing randomized trials to a few specific situations may be possible. Any potential benefit has to be carefully weighed against the risks of intervention. We currently have a study by Azura et al. To look at the effectiveness of early lens extraction with intraocular lens implantation as treatment for BACT, what is known as the EAGLE study. It's a multicentric randomized trial. A single main analysis will be done at the end of the trial, which is at 3 years of follow-up. 400 participants with 200 in each group. The quality of life, vision, intraocular pressure, stability of the disease, safety of interventions, and economic implications are being looked into. The results should probably be out this year. In conclusion, earlier removal of cataract seems to be a reasonable option in primary angle closure disease. At present, there is no published data to guide the use of clear lens extraction for this condition. The results of the EAGLE study to address the practical question of clear lens extraction in primary angle closure disease